I got tasked, unfortunately, with the topic that might have only appealed to half of the audience. But we know at the Chiari Institute, there's probably about 2/3 of our patients are women, so maybe I'm making a little bit better than that. But this is a very interesting topic that I got a little more personal interest in the last couple of years as I've fielded more questions from patients. And this is a common circumstance that comes up. You've heard a lot of really authoritative, and it's sometimes confusing because that's what it is, confusing as far as the issue of Chiari. But one thing we're pretty good at is diagnosing pregnancy. So that's a given, kind of. So we're halfway done there. My disclosures, everybody's used to have to disclose everything now. So my disclosures are that I'm neither a neurosurgeon or an obstetrician. So I don't know what I'm doing up here, really. But I'm also happily married for 41 years. I have 4 children and 2 daughters, and personal experience on that side with pregnancy, labor, and delivery, and 4 grandsons. So no personal experience, however, obviously. So what are the general questions? What are the general questions? And I kind of got, taking after Letterman a little bit, the kind of a 10 sequence of clinical questions that I think come down to the most important things that I get asked about by patients. And some of them I had to do some searching and thinking about, really, to get good answers for, so I hope they're helpful. We'll deal with them kind of one by one, and they should have passed out to you a list of the same questions. So one of the questions is, does Chiari affect fertility and the ability to sustain a pregnancy? And not that we know of. So things are pretty normal that way for the Chiari patients. But I should emphasize to you that 10% of couples have difficulty conceiving. And it often takes a number of perfectly timed cycles for a pregnancy and to come to fruition. And for a young woman, it's probably about perhaps a 6-month period. And if you're over 35, it may be 6 months to a year or so. And so getting there is, of course, half the battle. And then the question comes, if you're pregnant, what are some of the issues if you have Chiari? And not only are all Chiarians a little bit different with respect to differences in how symptomatic they may be, whether they've had surgery or not, whether they have syringomyelia or not, and then differences in the pregnancy itself, because like every child is as different, every pregnancy is just as different as well. So there are different issues that may come up in that extent, and differences between what we call a primipara or a first pregnancy from subsequent pregnancies. So will my Chiari symptoms get worse during a pregnancy? This is a very interesting question. And a lot of what I'm telling you is kind of speculation. It's kind of personal interest on my own and some experience dealing with patients. There's very little in the literature. Dr. Oro and his associate, Dr. Mueller, had put together a paper. There's 1 or 2 others that are very anecdotal. Many of them are case report oriented. So there's not a lot of comprehensive information in. At the Chiari Institute, we must have screened somewhat in excess of 5,000 Chiari patients, and so we have some kind of idea. That's the sense I come with. I have to admit humbly that we really haven't analyzed it as well as we could have or should have in terms of coming to clear notions about all these things, but that information should be available, and it's largely obtained from you all. And so we get people at different times in their existence. For instance, we have the experience in many women who have had 3 or 4 relatively normal pregnancies before they turn 45 and become symptomatic with Chiari. So that's kind of an interesting experience. I mean, we can benefit from that, but it goes kind of unsaid in many circumstances. Perhaps the more troublesome situation is a young woman who has a Chiari malformation, finds out she's pregnant, and then the question is, oh my goodness, what do I do now? How bad is this? How good is this? What are the risks? And that's kind of what we're gonna focus on in that sort of overview or perspective. Interestingly enough, confirmed by some of the few reports, many women seem to do, I would say, and it's my experience, unexpectedly well during the 2nd and 3rd trimesters. And they, of course, many of them go off any medications that they may be on. Some can continue narcotic medications, which are not necessarily desirable, but not terribly harmful as some other drugs might be, for instance, at least to relieve pain. But some drugs like Diamox and Topamax, for instance, are what we'll hear are class C and D drugs, and something that someone ought not to be on, particularly in the first trimester of pregnancy. So why women may do a little better, I'm not so sure, whether it's got to do with progesterone, whether it's got to do with just the blissful state of being pregnant. My wife would have stayed pregnant as long as she could, but she loved being pregnant, but that's not the same for everybody. But there is something about a gifted state in those precious months. As a rule of thumb, it still holds true, as you've heard from other speakers, that the more the tonsillar descent, generally, the more we might expect symptoms to be that case. Of course, we don't operate on x-rays, we operate on patients, and we get concerned about what their symptoms are. We just don't depend on what the tonsillar descent is in a simple fashion. So the questions of how to get through pregnancy, labor, and delivery in someone with impacted the foramen magnum like this is kind of got different issues than someone who's had decompressive surgery and is wide open and frankly can, despite perhaps being the same patient, this person has much, almost the normal set of options in terms of looking at the issues of how to carry through labor and delivery. Might I need to have surgery before I get pregnant? Well, not necessarily, because we don't recommend Chiari surgery prophylactically, and we don't operate on people that don't have symptoms. So if you're not terribly symptomatic and you get pregnant, well, we'll deal with that. But we don't sort of think that you ought to plan necessarily to have surgery if you're not symptomatic. Now, if you're very symptomatic, we would certainly say, hey, you might have a little more difficulty during pregnancy. There are some dicey issues here, and you're thinking about how bad off you are with a headache. You're dependent on many medications. Maybe if you're symptomatic enough to say, yeah, I'm ready for surgical intervention, then if you want to do that and structure that, then maybe have the surgery first so you're all set to carry through the pregnancy. And for instance, you know, kids are much easier to take care of inside than they are outside. So, I mean, if you think you're having stress when you're pregnant, I mean, when you give birth, that first 6 months of being up half the night, and feedings and all that is quite a stress too. So that's worth thinking about in that perspective. Is the baby at risk during a pregnancy? Well, this is a difficult question because actually both mother and baby are at risk during every pregnancy. I mean, pregnancy is a dangerous business. I tell my kids, you know, just going around New York is a dangerous business. Life is a dangerous place. And blessed mothers get through all this and really, to a certain extent, if you want to be honest about it, put their life on the line to a certain extent. Infant mortality in the United States, so even if, no matter what you're thinking about the hereditary aspect of Chiari, 1% of children have an infant mortality rate, die within the first year. The instance of birth defects is one in the March of Dimes data is 1 in 33 live births have some kind of genetic developmental abnormality that may be significant or not. And every woman puts herself at risk to other eventualities such as preeclampsia, eclampsia, and the risks of surgery, labor and delivery, and the like. So there's no such thing as a risk-free pregnancy, all right? So, and Chiari just sort of colors that with its own set of issues, but pregnancy and not to mention raising children is a big responsibility and an important business. Probably the greatest risk to the mom and child is preeclampsia, because this is an incidence of about 6% or more, hypertension and other problems. That Chiari doesn't necessarily make this any more a risk that I'm aware of, but pregnancy itself leads to a slight increase in intracranial pressure because of the weight of the fetus on the venous system, and that's so it adds as an augmenting factor perhaps to this that's worth taking into consideration. We get asked a bit about medications, and not only to think about this when you get pregnant or if you're pregnant, but before you get pregnant and just in general. There's a class sequence that identifies the risks relative to the fetus for pregnancy, and the classes of drugs are A, B, C, D, and X. So you can imagine what X is. They've skipped enough letters in between, so this is a bad situation. These are mainly anti-cancer drugs and immunosuppressive drugs and the like that are not usually very common in young childbearing age women, thankfully. But there are some drugs that we consider pretty good, like pyridoxine and vitamin D low dose. But every OB and everybody else ought to tell you that you ought to best be on no medications at all if you're pregnant, because thalidomide started out as this kind of a thing. Everybody thought it was good for nausea and it wasn't too much harm. We found after a number of years that it produced focomelia, or these children with little stubby arms and absent limbs. And it was a terrible, terrible situation, and it was until it was recognized as a cause. Class B drugs are fairly commonly used, like Tylenol, Benadryl, and even some of the pain-relieving drugs. So pain-relieving medications, everybody says, oh, I'm going to have to give up all my OxyContin or oxycodone. And that's not necessarily true. If you're on high doses, you can certainly have a child that will have some addiction issues and may have to be weaned off, but if it's kept to a minimum, you still have that as a support for pain control. These Class B drugs have gone through animal studies and some human studies. Basically, they don't have any good evidence that it harms animal fetuses, and there may not be some good studies in humans, but we think that they're probably somewhat safe. Class C drugs are what most things are, frankly, and those are drugs that we have some question about. That animal studies have shown some adverse effect, but there's no good studies in pregnant women. And so we use these with caution, try to stay away from them. From our standpoint, the Class D drugs are oftentimes antidepressants, benzodiazepines, and Topamax, which is an important one to remember, because Topamax is frequently used as a drug to partially decrease intracranial pressure and for the treatment of chronic daily headaches. So this is the magic bullet for migraine clinics, and everybody that goes through those probably has some exposure to Topamax. Topamax used to be a Class C drug. It was in the last couple of months it's been dropped down into Class D status. So they have a fear, that it has demonstrated some risk toward fetal malformations. Interesting thing here is aspirin turns up on this D list, which surprised the heck out of me when I actually looked at the data. I'm not sure I understand that, but Tylenol is pretty good, but aspirin is worth staying away from. So in many of the compendiums of various kind of drugs, they'll give you a list of these and tell you what drugs are. Most of the Hippocrates and other drugs always list what the risk is, the fetal risk. What are the risks that my baby will have, Chiari? Well, we used to think it was quite low, and you've heard a lot of information on this, so I'm just going to breeze over this pretty much. I think there was some new information presented here that suggested that there might be a 10% familial instance. That number keeps going up a little bit, and I suppose when we look at how sensitive we are to things like EDS and Chiari and posterior fossa smallness and hypoplasia, and many factors involved in Chiari malformation, that number and risk thought is going to continue probably to go up. But I don't think we are recommending to people now that if you have Chiari and there's no strong family history available, that you ought to not get pregnant. I mean, nobody would say it's not like hemophilia or whatever, that you ought to really not get pregnant. It's more on the order of diabetes or hypertension, and we all view those as risks and try to deal with them. So recent studies, we heard today, there are recent studies showing that there are more suspicion that that there are genetic underpinnings to these diagnoses. Will a pregnancy make my Chiari symptoms worse so that I have to have surgery? Well, there's not too much good data on this, but we know from, if we go back, harken back to the Miller paper from '99 and the redefinition of Chiari malformation, we knew that head injuries can be an early inciting cause in about 25% of patients. And I went back and looked at the data. I hadn't thought about this before until I reviewed the paper. It's the beauty of going back over some of these publications. There were 16 patients in that study that reported that their symptoms were provoked after childbearing. Now, if you get down, there were only 275 women in that study, and the 16 referred to them. So it's about close to a 6% incidence, maybe, of not a high incidence, but maybe there's some suggestibility to that. I would say in my personal experience in dealing with patients, I'm more impressed with the patient that comes in at 30 or 35 and says, I've had 2 children, I've had 3 children. I never had a problem with labor and delivery. I had epidurals, I had this, I might have had a C-section for this, but they really didn't know they had Chiari. They'd not been understood to have a problem. They hadn't had headache symptomatology, and they did quite well, just as well as anybody would have suspected. So we don't have hard numbers, and we should get those for you because I think it would be interesting. So the view in the literature, again, is very, very limited, but nothing that raises a lot of red flag. What are the options? This is probably one of the most important things. What are the options for pain control, and how safe are they, and what are the issues with the anesthesia approach? And this comes to a head at the kind of termination of that 9 months of pregnancy in the last month when we're trying to make these decisions about how the labor may take place, how big is the baby, how the mother tolerated the pregnancy, are there any medical issues like preeclampsia, hypertension problems, and that may come to bear. And so there are a lot of things that anesthesiologists do that helps with childbearing. Certainly we start off with just opioids that certainly can be given to calm folks down. And the only problem with opioid administration during labor and delivery is it slows down labor. So there's always this playoff between keeping you comfortable and slowing down the labor. So they do use that pretty judiciously. Now there's various kinds of regional anesthesia, and these are generally in the purview of the obstetrician. They can block the areas of the cervix. As the cervix dilates, that might be painful and effaces. There can be the use of pudendal blocks to block the perineum for episiotomy and stress of the lower end of the birth canal. So anesthesiologists usually take care of this. If you look at what's happened in the last couple of maybe decade or so, there's been a higher and higher use of epidural and combination epidural or spinal anesthesia, which is still, there's quite a bit of confusion. Well, what are the issues with Chiari? Well, what's the risk of epidural anesthesia? Well, the thing we're all concerned about is inadvertent dural puncture, because to give you or administer epidural anesthesia, they have to use a relatively big needle. This is practically what goes on, because they feed a rubber catheter down through that needle and to the epidural space, not violating the dura, and they can continuously administer analgesic medication through that, and it's become extremely popular. About 60% of labor and deliveries are done under epidural, elective epidural anesthesia. Our concern, again, is one, and that's another reason for full spinal imaging, to be sure we're not dealing with any terminal neural tube abnormalities like a lipoma or tethered cord syndrome. And we know that the access might otherwise be not a problem. And then the question of puncturing the dura. Now, the risk, it turns out, I was surprised because I thought it was a little higher. I thought it might be 5 or 10%, but the anesthesiology texts in that quote a 1% incidence or less of wet taps or epidurals. Now, how can you weigh that? Well, one of the problems with epidurals is if everything comes to a head and the labor and delivery is quick and everybody's in pain, not doing a planned epidural is a lot more risky than waiting till the last minute when the baby's head's pounding and the person might be in a lot of distress and pain. So kind of doing this early as a consideration keeps it safer. And there's less risk of, of puncturing the dura and getting a wet tap. So this epidural anesthesia is really pretty safe, and we're happy as neurologists, that it doesn't violate and get into the subarachnoid space. One of the problems with epidural anesthesia, well, if they have to go into doing a C-section on an emergent or subacute basis, and that decision is made because labor generally may not be progressing or the baby's in distress, it is harder. The use of epidural may not give you pain relief enough, so they may have to give like general anesthesia on top of that, propofol or inhalational anesthesia, and they may have to then either give general anesthesia or opt for possibly even doing spinal anesthesia. Now, our concern, what about intradural spinal anesthetics? Well, in the 40s, spinal anesthesia got a terribly bad name because it was the cause of arachnoiditis and paralysis, sometimes in paraplegia in women. The anesthetics that are now used are relatively safe, so that intraspinal anesthesia is a relatively worth considering kind of option. The issue with wet taps, of course, we're violating the dura, entering the dura, but techniques have been developed to use a larger needle close to the dura and use a 27 gauge spinal needle to actually get in within the dural space. And this can be relatively safely done. And in fact, in our anesthesia hands, we have an obstetrical anesthesia group that really probably favors spinal anesthesia, though we're concerned about epidural inflammation in that over general anesthesia. General anesthesia, of course, has its own risks. Why are the anesthesiologists concerned about general anesthesia? Well, there's the issues of intubating the individual, there's the issue of cough, vomiting, aspiration, all the risks of general anesthesia that they'd rather stay away from. Babies, however, are generally not born anesthetized because before they get you under, the baby's out, and most of the babies don't need to be reacted out any more than getting a light oxygen. So anesthesia can be pretty safe. These are all factors in a consideration of where these agents operate in the complex biology of pain and labor and delivery. I won't belabor that. And this was the issue with how and where the epidural needles are placed and the risk of getting a wet tap. Other risks like an epidural hematoma, these are all incredibly, infection and other things are incredibly low risk issues. So those things are relatively safe. What's the trend now? As I said here, you look here, about 60%, 2001, about 60% of the large hospitals were carried through with epidural anesthesia, and about emergent spinal anesthesia is inching up there higher, and general anesthesia is relatively less of an issue. So, how does having syringomyelia affect my options? Well, it usually makes us a little more cautious because of the size of the syrinx. Now, this syrinx is not so risky in terms of rupture, so we have maybe fewer concerns. Tiny little central canal dilatations as well, but a larger syrinx has the potential for rupturing in the heavy pushing of the second stage of labor and delivery. So that gives us pause and opts us more to consider general anesthesia with no pushing whatsoever. So what are the conclusions? Virgin Chiari patients need to be handled with the expectations driven by prior symptoms and prior imaging. So know what's going on before you get pregnant. Patients having been decompressed often have the full range of options dictated more by other factors determined between them and their obstetricians. And patients with syringomyelia ought not to push in the second stage of labor because of the risk of rupturing a significant syrinx. And there are some potential risks also in that category of chemical meningitis and the effects on intrathecal analgesics. But this looks like it's very low. So what is the issue in the end? Plan. Be considered as a high-risk designation. have anesthesia consultation first, and there needs to be a team approach between the obstetrician, the anesthesiologist, and neurologist and neurosurgeon. Thank you.